Okay, so good evening, everybody, and welcome to this postgraduate lecture series. And today we're going to talk about a very interesting issue of hypernatremia. As you are aware, the postgraduate lecture series is focusing about different aspects of pediatric endocrinology, and we are planning over the next 3 years to complete about the entire aspect on that regard. So we had this 14-year-old girl who presented with failure to thrive. And actually at 14 days, she was lower as compared to the birth weight. And that's a very significant finding in that perspective. She was entirely breastfed and was found to have a sodium of 182. So this was a very devastating scenario, very difficult to manage. And what it was found out was that this was actually what is known as breast milk related hypernatremia, in that there was concentrated blood of a sodium very high and concentrated urine, meaning that body is trying to eliminate sodium but it is unable to. So this was a breast milk related hypernatremia, which is a lethal condition, a avoidable condition, which we should try to avoid if there is enough feeding evaluation in that setting. A second situation was more of a iatrogenic problem. A 3-month-old girl with altered sensorium was found to have hypernatremia, sodium of 170, and a urinary osmolality was low. Now, as I'll discuss in the first case, the main thing to look at hypernatremia is what is the urine. If you have a concentrated blood and a dilute urine, like in this case, your diagnosis of diabetes insipidus is already made, and you do not need to worry to do anything else. You have to go for an AVP response. Now, what unfortunately was done in this case was that they were advised a water deprivation test. Somebody who's already water deprived, who has a severe dehydration, if you do that, will develop seizures. So while we need to be careful in terms of assessment, we need to know what will be the right strategy. And this is what we'll discuss subsequently from that perspective. So hypernatremia is a relatively rarer condition as compared to hyponatremia, which we discussed last time. But this is one which is associated with significant complications in both in terms of assessment, in terms of management as well. And this was a classical case of DI in which we didn't need to do any water deprivation, and easily we could have made the diagnosis in that perspective. So today we are going to talk about a bit about pathophysiology. Then we'll talk about criteria and etiology by Dr. Sain. I'll touch base about evaluation and management. And finally, we have the Q&A session in which we'll keep it interactive. So all of you can put your answers and we'll see how well our class has gone in terms of that, in that scenario. All of you can go and have a look at our website, learning.growsociety.in, which has got multiple information pathways, courses with regards to pediatric endocrinology, YouTube site, which has got multiple videos, and a learning platform which provides evidence-based validated learning in pediatric endocrinology using practical tools for diagnosis and assessment in that regards. We specifically have a 3-year online and a 2-year offline fellowship program in pediatric endocrinology, along with pediatric endocrinology for postgraduates, specifically targeting the topics which are very, very relevant for pediatricians and pediatric endocrinologists in the form of growth, puberty, thyroid, calcium, electrolyte, and it has got a lot of interactive videos, texts, which are available from that perspective. We cover 3 specific free webinars every month in the form of specific to a particular topic, which is relevant for a pediatric endocrinology perspective, from a pediatric perspective, and finally, the postgraduate lecture series, which we try to cover specific topics. And we have a schedule which is there for the next 3 years, which will basically cover the entirety in that scenario. We've got publications, both basic and advanced pediatric endocrinology, to cover the entirety. And you can access our mobile application, which provides validated tools to evaluate, assess, and manage complicated endocrine conditions like hypernatremia. 3 major questions that a clinician has to answer while facing an individual with hypernatremia is it really hypernatremia? If it is hypernatremia, is it a free water deficiency or a sodium excess? And finally, what is the cause? So now hypernatremia, we all know, basically the symptoms will depend upon the levels of sodium. So as we discussed, if the sodium goes up, there will be an exodus of fluid from the cells, which will shrink in that regards. So the acute symptoms of hypernatremia can be quite severe. If it's a rapid development, there will be altered sensorium, seizures, and hemorrhage may happen in that regards. With the time, the cells will produce their own idiogenic osmoles, and these idiogenic osmoles will restore the cell structure, and these acute systems will go off, It will present more now with fever, recurrent dehydration, failure to thrive. The classical presentation of nephrogenic diabetes insipidus is a 6-month to 12-month-old boy with complaints of recurrent dehydration, developmental delay, and fever, rather than an issue of hypernatremia, rather than polyuria, because they don't drink enough water, they become dehydrated. Now, if you do a rapid correction of this hypernatremia by giving too much free water, or you're giving vasopressin, you will have a sudden change in the overall flux, and the cells which were shrunk will now swell up and cause features of cerebral edema. So the acute manifestations of hypernatremia, as I said, are more towards cell shrinkage. The effect of treatment may actually cause cerebral edema in that perspective. Now, manifestations will depend upon the levels and the rate of rise. So if you have a chronic hypernatremia, as in chronic hyponatremia, the symptoms will be less. If you have acute ones, the symptoms will be more in that regards. So typically symptoms start from around 155 in the form of irritability, dovey skin. So they will be less dehydrated clinically than they actually are. So you will underestimate the level of dehydration, as you also do in diabetic ketoacidosis. Seizures typically happen beyond 165, and drowsiness and coma, of course, at a higher level. Now, as I talked about the first case of a sodium of 182 in breast milk hypernatremia, they will actually present with absolutely in the form of unarousable, in the form of decreased activity, and that will be the presenting features in that regards. And finally, you can have an intraventricular hemorrhage, which could be lethal in that perspective. Now, when should we suspect hypernatremia and diabetes insipidus, which is by far the most common cause? If you have seizures and altered sensorium, always get a sodium done. If you have a dovey skin with dehydration, think of hypernatremia. If you have unexplained fever, unexplained dehydration, unexplained developmental delay in an infant, always get electrolytes done. It could be a manifestation of nephrogenic diabetes insipidus. Now, hypernatremia classically is defined as a serum sodium above 150. Usually between 145 to 150, you will not have much symptoms. Very importantly, the site is important. So if you're taking a capillary sample, remember that the capillary sample may underestimate the severity of hypernatremia because it is lower from venous sample by 2 to 3 millimoles per liter. So if you're looking at a venous blood gas, you have to maybe add a couple of points before you really say this is not hypernatremia. The problems, of course, are that if somebody had seizures or a lot of exercise in a particular area, the release of sodium can cause a transient increase, which will then normalize over time. If your albumin levels are low, so we talked about hyperproteinemia, hyperlipidemia, and hyperglycemia as causes of pseudo-hyponatremia. Similarly, if the albumin level is low, your sodium level will be falsely high in that regard. So these are the scenarios which you need to be a bit cautious about. Now, once you know it is hypernatremia, the next question is it free water deficiency or sodium excess? The answer to that is pretty simple. We talked about hyponatremia. We said the most important thing to look at is the volume. Here again, volume status will give you a clue. So if somebody is having polyuria and dehydration, you're mostly dealing with a urinary loss of free water, and it's more like a free water problem. Specific pointers to diabetes insipidus are nocturia, preference to cold water. Now, why do they prefer cold water? Is that the throat receptors are very sensitive to cold. So if you're taking ice or if you're taking cold water, they will be satiated earlier. So cold water preference, watery urine with no odor classically will go in favor of diabetes insipidus. Ask about history of diarrhea and whether ORS has been prepared, which is one of the most common causes of hypernatremia in infancy in that regards. And of course, ask about feeding, dehydration, that will give you a clue in that regards. So if we compare free water deficit versus sodium excess, you will have a low urinary sodium and dehydration in free water deficit, and sodium excess will have a high urinary sodium and a fluid overload in that perspective. Now, the final question is, what is the cause of hypernatremia? You have to go to clinical examination. As science said, always if you have a 2 to 5 year old child with hypernatremia and polyuria, look at rash, ear discharge, organomegaly, seborrhea. This could be a classical feature of ichthyosidosis. Look for midline defects, look for vision, roving nystagmus. This could be a sign of septoptic dysplasia in an early onset central diabetes insipidus. Hearing defects may be a manifestation of diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. The Wolframin gene defect. Take a very careful history of drugs like lithium in particular, amphotericin B, and tubulopathy causing drugs like ifosfamide. Look at micropenis, which may be the only indicator of multiple pituitary hormone deficiency and development, which may be impaired along with unexplained dehydration in nephrogenic diabetes insipidus. Look for neurological features, CNS insult, and look for infection. That will give you a clue. Now, the most important investigation once you have documented hypernatremia is to look at the urinary osmolality. You have concentrated blood. Now, your urine is concentrated or not is the question. Everybody who has a sodium above 145 or a osmolality above 300 should have a urinary osmolality more than 600. Less than that is DI and less than 300 is complete diabetes insipidus. Urinary sodium will be relevant if you have got a high urinary osmolality to look at whether the sodium is being lost or you have an alternate osmoles, as Sam talked about osmotic diuresis. So if urinary sodium is low, you're dealing with an extrarenal loss. If urinary sodium is high, you're dealing with a salt load in that perspective. And finally, don't go for water deprivation, go directly for a vasopressin response. If somebody has hypernatremia and you give vasopressin and your urinary osmolality increases by 50%, this is central diabetes insipidus. If the rise is less than that, it is nephrogenic diabetes insipidus in that regards. So vasopressin test basically is done if you have hypernatremia and a low urinary osmolality, concentrated blood, dilute urine. You give aqueous vasopressin 0.1 unit per kg, look at urinary osmolality at 2 and 4 hours. If the urinary osmolality rises more than 50%, this is central DI, less than 50% is nephrogenic DI in that regards. So if you look at a normal response, as your plasma osmolality goes up, your urinary osmolality should really go up. And if you give them AVP, there should be no effect in that regards. But if you have diabetes insipidus, even if the plasma osmolality is going up and 300 is taken as a figure, you will have still a dilute urine. If you give vasopressin and there is a rise, this is complete central diabetes insipidus. There is no rise, this is complete nephrogenic diabetes insipidus. So basically, if you want to classify AVP response is the best way to identify. Your picture doesn't end there. You have to look for neuroimaging, in particularly if there's central DI, and look for renal imaging. Another workup, it's nephrogenic DI. Beyond that, we are not focusing because we're focusing more on hypernatremia today. So just to summarize the approach, start with salt load, mannitol, diabetes, which may be the rarer causes of hypernatremia. If they are not there, look at urinary osmolality. If urinary osmolality is less than 600 in hypernatremia, that is diabetes insipidus. If the AVP response is present, this is central DI. Absent, this is nephrogenic DI. If, on the other hand, you have got a concentrated blood and a concentrated urine, look at urinary sodium. A low urinary sodium in this setting means an extrarenal loss. A high urinary sodium will indicate a sodium load in that perspective. So the most important investigation here is urinary osmolality and then the AVP response to identify DI in that regards. So we'll start off this cases. So this was the first case we already discussed. 14-day-old girl with failure to thrive and had lost weight, was breastfed, high sodium, and this is a classical case of high urinary osmolality and high urinary sodium. So this is a case of sodium load. This is what we know as breast milk hypernatremia because of inadequacy of breast milk, as science so nicely talked about. The key here is to measure the birth weight at 14 days in that scenario. 6-month-old boy with dehydration, dovey skin, we already discussed this, sodium 178. So now we have hypernatremia. The next question is, what is the urinary osmolality? Urinary osmolality here is high. So what we are looking at, look at urinary sodium, which is also high, which basically means the sodium load. And what was found here was that there was a diarrhea and inappropriate ORS was given in that scenario. So this is a classical example of hypernatremia because of sodium load, because the ORS was not prepared adequately. 3-month-old girl with altered sensorium, already discussed this case. Hypernatremia, advised water deprivation test. Very important message. If you already have hypernatremia, do not go for a water deprivation test because it is not required in that scenario. A 6-month-old boy with failure to thrive, hypernatremia, and what you are seeing here is that the urinary osmolality is low. So you have concentrated blood and dilute urine. This is diabetes insipidus. If you have a 6-month-old child, I think you should start thinking of a possibility of nephrogenic DI already. There is no AVP response. So this is a case of nephrogenic diabetes insipidus, and you have to manage accordingly. So if you look at a combination of urinary osmolality, you will get the diagnosis. 3-year-old boy with polyuria, sodium is 154. You have to look at urinary osmolality, which in this case was low. So concentrated blood, dilute urine. This is diabetes insipidus. The next question is this central or nephrogenic? You give a vasopressin response, the urinary osmolality increased by around 120, which is more than 50%. So this is central diabetes insipidus. The next question is, what is the cause? So you look at the child, he has got rash, he's got seborrhea, he has got hepatomegaly, he has got bony defects and lytic lesions. So this is classical case of histiocytosis, which is causing these problems. So basic evaluation will give you the diagnosis in that regards. Very important case, 13-year-old boy with encephalitis on ventilator has developed polyuria. Sodium is 180, very high serum sodium, and urinary osmolality low. So this is diabetes insipidus. But why does this child with encephalitis has developed a DI? The reason for that is that there is a diffuse brain damage. And this is what is known as a brain death DI, a very poor prognostic feature. And this is a scenario which we need to be very wary of. If you have a child on ventilator, suddenly starts to pour a huge amount of urine, you're dealing with a brain dead DI. The prognosis there is very, very bad. You can all go and have a look at our website, applications, and books. I'll really thank Dr. Naveen and Dr. Sayan for being part of this program, and they've really made it very, very interesting.